Well, good afternoon, everyone. Welcome to this Medscape education series, Optimizing Outcomes with Long-Acting Injectables with HIV. I'm Jason Farley, the Director of the Center for Infectious Disease and Nursing Innovation at the Johns Hopkins University School of Nursing, and I'm joined by colleagues Dr. Rupa Patel and Dr. Joshua Havens. Dr. Patel is a research associate professor from the Washington University School of Medicine, as well as a clinician at the Community Health Department in the Whitmer-Walker Health in Washington, D.C. Dr. Havens is an associate clinical professor at the College of Pharmacy at the University of Nebraska Medical Center. Welcome, Rupa and Josh. Good afternoon.
It's great to be here. Yeah, thanks.
Excellent. So as we know, this is a follow-up to our conversation that we've had on Medscape about implementing long-acting injectables for HIV prevention and treatment, and really thinking about the use of these in clinical practice. And so as we think about who's the right kind of candidate and who might not be the right kind of candidate for such therapies, Josh, why don't you tell us who you consider to be kind of the optimal candidate for long-acting injectables?
Yeah, it's a great question. I think if you asked a lot of different providers, you might get a variety of different answers, to be quite frank. To me, I think it starts with two different components. You have the patient, and then you have some clinical factors, so more on the provider side. With the patient, I think it's all about, are they interested? Is there excitement there? Do they understand what they're getting into in terms of what's the risks and benefits? What's going to be expected of them in terms of keeping visit appointments, making sure that there's bridges if they need those from an oral perspective. Communication, do they have the communication to make sure that if there's a gap in their visit schedule, can we get them to the visit, or do they need a ride, or do we need to get them oral bridging? And really the commitment, do they have the commitment there to really be successful with long acting? And then on the clinical side, there's a number of considerations. I think there's really a couple from a perspective of good candidates that you should consider. Number one would be resistance, right? So I think if there's any archived resistance there that's going to be applicable to cabotegravir or rilpivirine, that would certainly need to be addressed, right? In some cases, you might have providers that might say, for example, if you have one mutation that's persistent with rilpivirine, maybe there's some studies that say we can add lenacapavir too. So I think you have to consider a lot of different routes. But if we're just keeping it simple, if you have a resistance mutation to cabotegravir or rilpivirine, probably should maybe think twice in just a simple setting, right? The other one that also comes up is viral suppression. Again, you could take this a number of different ways, but from the clinical trials, viral suppression was needed in order to go on long acting, right? And so It's preferred. There are demonstration products or projects now that have looked at using long acting injectables in the setting of folks that have viremia, and that requires a lot more support and a team factor just to have all that support there. But I think those would be the core things that I would suggest in a good candidate.
Excellent. Well, like a good candidate, there's also such thing as a good moderator. And what this good moderator forgot to say to everyone is, please feel free to type in your chat into the chat box any questions you have for us throughout the presentation. We're happy to address those live. Questions for any of our presenters or about anything that we've had to say throughout the talk. Also, when you think about the good candidate, how do you talk to them about dosing, scheduling, and how adherent one needs to be in the dosing scheduling for the injectables?
Yeah, I mean, the way our approach has been more to make sure that they understand not only the schedule itself, but the ramifications of if there is a gap or they miss that injection window, right? And if they really understand that, we can help mitigate those potential problems in the future, because the last thing we want is to put somebody on long acting and then have a problem and maybe they develop more resistance and then we lose certain classes, and that would be a problem. So I think a lot of it is education based. I mean, we sit down and we have a discussion, just make sure they understand if they are going to have a gap or they're going to miss a visit, we have routes to get them bridging, so that way that we can lessen the downside burden of, if they were to not have any antiretrovirals during that period. But that's generally, we take more of an education-based approach.
Sure. Well, juxtapose those who might not be the best candidate for long-acting injectables.
Yeah, and on the last slide, you would have noticed no Hep B infection, and I actually left that for this one because I think it's more not necessarily are they not a good candidate, but you need to consider, you have considerations, right? And so the number one thing with Hep B, I mean, a lot of our antiretroviral, specifically 3-drug antiretroviral treatments, will have treatment for Hep B and HIV together, right? And so oftentimes we're so used to that we might forget about it. And with long acting with cabotegravir and rilpivirine, there is not a built-in component to treat Hep B, right? So it's not that you can't use cabotegravir and rilpivirine, it's just that you would have to have another drug, or drugs in this case, on board too, typically oral, that you would have to give as well. So I think Hep B you have to consider that, because if the person wants long acting and that's the route you want to go, you'd also have to say, hey, you're still going to have to take a pill for hepatitis B, right? And they may not want that. So that would be something that you'd have to consider. Certainly we know that higher BMIs, there's risk that the depot might not get to the muscle, and that would be a problem, right? And we've seen associations with that in certain trials. And so particularly with those with BMIs over 30, we would use a longer needle. So the 2-inch needle would be indicated in those cases. That's our practice in our clinic. We do that. And the kind of the third thing would be drug interactions. These are, in my perspective, they're rare, right? They're there, and really what you want to be consider is, if you're familiar with CYP3A4, that's kind of the primary substrate you want to be cognizant of, because both drugs are substrates through that pathway. And any other medication that's going to speed that metabolism up and get rid of cabotegravir and rilpivirine faster, that's what you do not want. So you'll see on the slide here, there's several drugs that are listed. Common ones would be anti-epileptic drugs, which can sometimes be used for bipolar disease too, so you got to be aware of that. Rifamycin, so things like rifampin, rifabutin, those types of medications. Dexamethasone, particularly injectable. And then, of course, St. John's wort is the other one we have listed. There's not many more. There's several more that we could have listed, but these are the more common ones. And lastly, I would say it comes down to the patient too, right? So you have to consider, is this patient going to be committed to care? Are they going to stay in care? And if you feel like that's a little bit wobbly, but it's still they're a good candidate, there's ways that we can provide support to engage that care, right? And so we have to consider that. There's been other studies that have looked at in the past year, if people have missed visits, is that associated with missing visits when they're switched to cabotegravir and rilpivirine? And that was true, right? And I think it's something that it's more about open dialogue with the patient, in my opinion. And really, we have to just make sure that the patient really understands. So again, it comes back to the education with the patient. And lastly, there's certain populations we had noted in our other presentation, correctional facilities, folks that are in and out of the correctional facilities, and that's a setting where not all facilities are going to have access to long acting, and I think that's really the key point. It's not that somebody on long, because inevitably you're going to have somebody on long acting cabotegravir or rifampin go into the correctional facility, and how do you manage that? How do we make sure there's no gaps, right? There's a lot of considerations that we have to take in that setting. But ultimately, in our state anyway, we're right on the border of Nebraska and Iowa. We have a lot of flux between states. And even folks that are seeing us, and then they decide, hey, I'm just going to move to the other side on Iowa, and then they have a different provider. There's got to be some coordinated communication to make sure that there's no gaps in care there. So those are things that I think about in terms of who you'd want to maybe think twice about in terms of long acting for treatment.
Those are great comments. Rupa, you want to toss in any additional thoughts you might have?
No, this was a great discussion. I just want to reiterate some of the timing and again the mobility, just so you don't have an interruption in the injections, because nationally we don't have everyone that has incorporated injecting in their clinic. So if someone moves, it's not as easy to walk into the next medical center like we did with HIV care in a large city. Some large cities and large centers don't have access. So just reiterating that up front and having a plan over the next 6 months to 12 months. Many people have actually tried to sit down and make a 12-month schedule with the client, so they they can see the whole 12 months and every 2 months coming with them. So that's just something to think about for long-term planning.
That's a really great point. As patients are very mobile, they move from place to place. I think we as providers really need to help them navigate, if they're on long-acting injectables, to another facility that may have access and the capacity. So Josh, thinking about that from your perspective, this is a slide that really sings to your heart, because you've done a lot of coordination about the logistics of bringing in long-acting injectables to your center. Tell us about what's going on here and of these different models of care that we see before us.
Yeah, I would say this is kind of a rate limiting step for a lot of sites. And unfortunately, there is a lot of excitement around long acting. And I think there's times, like Rupa just touched on, where sites just don't have the capacity to provide some of the support systems that are needed, right? And Rupa's going to talk about some more things here on the implementation side here in a minute. But in terms of, I'll touch on coverage and access, right? So I'll keep it at that. So when I think of coverage, I think of if you have an insurance plan, so uninsured versus insured. If you have an insurance plan, what does that plan say? Is the particular product that you're looking at, is it on the formulary? And then you have to take it a second step with long acting, because a lot of times when we're thinking about, particularly with other oral antiretrovirals, we're thinking about pharmacy formularies, right? In this case, now we're thinking about pharmacy and medical, and depending on the plan, one plan might prefer a medical route, the other plan might prefer a pharmacy route. And so you're kind of dictated on what that plan says. And so then all of a sudden the clinic, or if you have a coverage or billing department that's handling this for it, is trying to determine, how are we going to get this drug, right? What's the best route of access? So this slide right here is talking about not only the site, because there are differences in the type of facility that you're at. And we've only listed 2 here. There's many more that you can consider. But really the route that you access the drug, right? So outside of assuming that the drug is on the formulary and it's covered, so you've already done the prior auth, you got it covered, how are you going to get it, right? There's actually there's 2 more options that aren't on this slide that I'll talk about, but one of the main ones is buy and bill. And the traditional route with buy and bill is the medical billing. And so what that would look like is a patient or the site itself, a clinic, would buy the drug from their drug wholesaler. They would give the shot to the patient, and then they would bill for that administration at the medical level. So it would all be taken care of at the site. The benefits of that is that if the site can handle it, is they can control a lot. There's a lot more flexibility and control in the delivery of the medicine, right? And then sometimes that's preferable. However, and that would be in the case of like a large healthcare system. But in a private clinic or a smaller clinic or an STI clinic, for example, that may not have all the resources available to do some of this coverage determination,
sure,
sometimes you can sub out some of the coverage stuff to other places, and you don't have to worry about taking on the financial risk of buying that drug, right? So in this case, there's a white bagging. And white bagging is basically where the clinic itself would order the drug to typically a specialty pharmacy, and the pharmacy would take care of all the billing, primary and secondary, at the pharmacy or medical level, and then they would send the drug back to the clinic for the patient to receive the drug in the clinic. So that's white bagging. There's also something called clear bagging, which again is not on this slide, but it's where you use your own facility pharmacy. The same perspective I just said with white bagging, but the drug gets brought back to the clinic for injection. Alternate site of using like an infusion center is a good example. So again, a similar scenario, the drug is ordered to a specialty pharmacy, but instead of it being delivered back to the clinic, it's delivered to the infusion center for an injection there, right? And then lastly, the other one that's not on here is brown bagging. It's a lot of bags here. And brown Brown bagging is when the order goes from the clinic to the specialty pharmacy, but this time it gets sent to the patient's home. The key question here is the drug administered at home? And right now, it's preferred that, the package labeling is that a medical provider needs to give that injection, right? Because of the volume, the size, and the technique. And for a patient to do that, that's a risk. So if the brown bagging situation where the drug is sent to the patient, the risk is that the patient might give it to themselves and do it incorrectly. That would be a problem. However, there's been some other projects that have looked at this and they've had it sent to the home. Somebody comes out, gives a shot, and that's been a good mode, because then you eliminate the transportation within all that consideration for that patient. So a lot of different routes to go. Can get confusing, but that's kind of the access and the coverage piece of the implementation that you really have to have a good handle on before you kind of start down this path.
Yeah, I know that here in Baltimore, our city health department was actually, as the end of 2023, the most had the highest volume of long-acting injectable use here in Baltimore City. And importantly to that, they used that white bagging approach with a specialty pharmacy external to them. And they were very successful, or have been very successful in that model. So if you're thinking about, in your practice out there, for those of you listening, hopefully you're thinking about alternative models and how you might be able to integrate this into your structure that works best for you, because there are, as Josh mentioned, multiple approaches. Well, it's carrying on down to some of the logistics and other considerations that we need to think about. And Rupa, let's turn it over to you to consider those workflow and visit planning considerations.
Yeah, no, I'm excited to talk about this because, we first talked about the individual level of administration of cabotegravir and rilpivirine. And then we talked about the policy and the structural level. So this really takes us to the organizational level when you're planning. And so the first part of the organizational level is going to be your workflow, your personnel, and then, kind of putting that all together so you can handle volume. Because I want to give the audience an idea. Once you get to 30 to 50 people, you're talking about 50 people that you have to coordinate every 2 months, if even sooner, every month. And then you have such a tight target window for getting that injection into someone so that they have the optimal medication levels. And that is a plus or minus 7-day window from when your target was for that person's schedule. And so there's about 5 main components to workflow. The first one is actually medication acquisition in the pharmacy. So first you need to go ahead and write the prescription, you get the medication, and you'll need to do billing related things related to the insurance. So you'll have to justify, you might have to do prior authorizations, etc., to talk about why this person meets the criteria for an injectable over a daily oral pill that may be similarly effective. And so after you have identified the medication is coming in, you actually have to coordinate it with the actual schedule. So that means you actually have to have slots in your scheduling system to handle bringing someone in for injection. And that would be after the intake visit. It takes about data that's come out from CROI 2024 did show that on average, it takes almost up to 4 weeks to get the injection in your hand, depending on all the paperwork that you have to do. Yeah. And then after you have scheduled, you will go ahead and administer the injection. And remember, around scheduling, you need the personnel to make the phone calls. And then after the clinician provides the injection, you must have documentation, because it goes back to buy and bill, what Josh just talked about. So after you have pristine documentation, the right billing codes, etc., then you'll have to turn it over to billing, who then has to talk back to medicine acquisition. They have to look at the financing and make sure the money's coming back if they pre-purchase in buy and bill. So the main 5 components, as a summary, is the pharmacy that does medicine acquisition, will be your schedulers, your navigators, your outreach personnel and support staff. It will then be your third, your clinicians, your workforce to inject. We see many centers now using nurses, medical assistants. There's a place in Washington, D.C. that I practice at that has community health workers. And then, of course, you need to have documentation. And I wanted to highlight documentation is not just your medical note. It's actually documenting you had a missed visit. So then you can call someone back. Because, you know, you will have discontinuation or you'll have delayed injections, and you have to keep on top of that. And many of us started with an Excel sheet. Then we moved into like a proper system that is in Microsoft, connected to the electronic health medical records, so you can have real-time reports like dashboards. So that's something to think about. And then the last one again was billing. Now, in terms of staff, I identified the 5 components. You need workflow. So obviously you need to have 5 components of staffing in these categories, as well as the orientations. The orientation required for billing staff is complex, and pharmacy staff. So I do recommend that on the last slide of this presentation, we actually have resources. And so you can get help from those resources, including the CDC hotlines that exist, and also the Curricula Center at University of Washington, Seattle. And I want to highlight patient tracking. That is the most cumbersome, especially when you get past 20, 30, 50. You know, you have to count 50 people, but then also injections every 2 months for each person, and all the calls you have to make for the first call to remind someone to come in, and the second call in case someone doesn't come in, or another call to reschedule. And then we talked about volume and the frequency of visits, and I think that's important to let to check in with the client at each time, also to remind them, how are you doing on this? Is this really good for you for the next 3 months? Because I'd rather have this discussion now than see you have a discontinuation or a missed visit or a delayed injection, and then we're in a bind at that time. Turn it over back to you, Jason.
Sure. So, you know, one of the things I think, because we're all 3 actively using long-acting injectables in our practice, both for treatment and prevention. So if I'm a provider and I'm new to all this, and I'm hearing, you know, as we've had this conversation, I'm hearing all these logistical kind of what sounds like a little bit of a nightmare. Talk to me about the clinical benefit on the patient side. Convince me that those barriers are actually worth it. And in addition, you mentioned multiple support strategies, but talk to me about the clinical benefits that you see, you know, as a physician in your patients who have switched to long-acting injectables.
Yeah, and so I'm going to take a bird's eye view. You know, there was plenty of presentations at CROI that where healthcare centers individually integrated the injectables for treatment. They saw their highest levels of suppression rates for viral load in their history. And that is because it is a game changer. It is directly observed therapy. If you can get to someone, whether it's in their home or giving them an Uber or a Lyft transportation mechanism or a taxi, you are really helping someone overcome pill stigma, et cetera. So on a organizational level, everyone must invest in the era of injectables. Today, it's cabotegravir, rilpivirine. We have many coming down the pipeline. We have things in the pipeline with multi-use technology. So that's the first thing, is you will have population benefit. And on an individual benefit, then it comes down to, you know, hearing the joy in someone's voice saying, oh my goodness, I am now consistently at goal and at target. I don't have to carry around pills. I don't have to hide them. I don't have to remember I have a chaotic schedule. I have family issues, I have work issues. So I think there are individual level and community level benefits. And again, we're also talking about zip codes that have, you know, community viral load. And it is our jobs as providers and part of institutions to work with their community health department or our local health department or a community division within our health centers to try to bring down that community viral load, which we can do now with the era of the injectables. And so just to highlight what's on the slide, fostering retention requires a very non-judgmental, non-stigmatizing safe space that we must create. Many of the providers listening here are adept to that, but as you get new staff and you have staff turnover, remember the power of making someone very comfortable. And if they forgot their injection, they don't feel like, they're gonna get scolded or have someone get annoyed, because it is a process to get used to this schedule. And then, of course, bringing in all kinds of alternative delivery to meet the potential of these very powerful injectables is important. So bringing in some task shifting and sharing, reach out to, Whitman Walker Health, Howard Brown, Fenway, some of these large centers that have actually incorporated multiple staff members to help with the injecting in terms of not only processing the schedules, but also delivering that injection. And they've gone through orientations and trainings that can help your institution. In San Francisco, they have had success with reaching individuals who use drugs and substances by having pop-up clinics. And I want to say that the power of after hours, bringing the care into the community, but also having flexibility in your clinic, so people can walk in. If there's one thing you can do from the get-go, now that you're listening to this session, is try to make walk-in clinic visits at least some part of the month, because that will really foster people who couldn't get there when you scheduled them. And then again, I think the key is, can you make your dashboard from now so you can actually in real time track your missed appointments? So spend some time on that pre-implementation phase for billing support and dashboards and electronic health records, and going ahead and making special maybe notes for the template for cabotegravir, rilpivirine, and tag those patients so you can query that for quality improvement. And so that is a good pre-implementation that segues into an implementation strategy.
That's fantastic support strategies. Those are all great systems. And just think also, providers out there, if you're overwhelmed by all the logistics, you still have the white bagging approach where you can farm all of this out to someone else, including the logistics of the prior authorization and thinking through the buy and bill and the approach and the structures. All of that can be done by a specialty pharmacy external to your practice or setting. So there are options where you do it all, or options where someone else does it all for you. So consider that. As we think about wrapping this up in the final couple of moments here, we've put together a series of strategies for you in a much longer set of webinars on Medscape education, which is now listed for you here on the slide. Full CME is available for these activities. You can listen to the three of us have a spirited conversation around each of these issues in a much more broad and lengthy detail if you would like. And we have a series of resources available for you on this next slide that will provide you with details on how you might consider implementing this in your local area. How do you pay for both treatment and prevention, as well as services related to clinical consultation. So check these resources out. In particular, the CDC's HIV Nexus. If you're looking for patient education materials about long-acting injectables that are non-branded, check that resource out for you to be able to prevent reinventing the wheel in your individual clinical practice settings. And then finally, I would just like to thank both of you, Rupa and Josh, for this conversation. It's as lively and energetic as usual. And all of you, thank you for participating in the activity. And if there are any feedback or additional questions you might have, now's your last moment to put them in the chat for about another minute here. Otherwise, we'll be happy to give my colleagues some time to wrap up. Any final words, Josh, Rupa?
Go ahead, Rupa.
Yeah, I hope you take away that this wasn't daunting, and we laid out steps that are concrete and feasible for you to begin the pre-implementation process. And really, please have your center join this wonderful effort to get long-acting or the era of injectables implemented in our nation. And thank you for all your hard work. I know everyone's busy at their own centers.
Yeah, I would just say, it's a great discussion, and really it's just all about planning. And in the end, kind of a lot of the stuff that Rupa talked about is really key. And so just making sure you have all that together and scaling appropriately, not like doing it too fast. And that way you'll be successful in the long run.
Certainly. Well, thanks to you both for a great conversation. And please check out the Medscape website for additional details and your CME. Goodbye, everyone.